Hi, everybody. It's Dr. Carrie Reller, your family medicine and obesity medicine board certified physician. It's still National Cholesterol Education Week, so I have another topic today for you. It's about triglycerides, okay? So let me share my screen, open my presentation. So, what about triglycerides? So, what is a triglyceride? A triglyceride is a lipid composed of 3 molecules of fatty acid. So here's 3 fatty acids, esterified to glycerol. Esterified just means that there's 2 alcohol groups here that combine together and make a triglyceride. There are also diglycerides and monoglycerides and even phosphoglycerides. So without going into organic chemistry, hopefully you can understand that. But so there are also nonpolar fats synthesized from carbohydrates or ingested. They are high energy molecules that are stored in fat cells for later use. So what is an elevated triglyceride level? So normal is less than 150. Borderline high is 150 to 199. High is 200 to 499, and very high is greater than 500. Up to 33% of adults in the US have triglyceride levels greater than 150. So what are some causes of elevated triglycerides? So pregnancy can actually cause elevated triglycerides, which is typically why we do not check a cholesterol panel when you're pregnant. Alcohol use or abuse, basically excessive alcohol use, which is defined as more than 1 drink for women and 2 for men, can increase that liver production of fatty acids and cause elevated triglycerides. Nephrotic syndrome and chronic renal insufficiency, those are kidney problems that causes decreased clearance of triglyceride-rich lipoproteins. And then endocrine diseases, such as obesity, metabolic syndrome, and type 2 diabetes, and even hypothyroidism. So the mechanism in type 2 diabetes is that it decreases the activity of this enzyme called lipoprotein lipase. So lipoprotein lipase is an extracellular enzyme basically on the arteries and veins surface that can degrade certain triglycerides in the bloodstream. So if the activity of that enzyme is decreased, then you're not degrading as many triglycerides and you obviously get elevated triglycerides. So actually some autoimmune disorders can also have antibodies against that lipoprotein lipase and also cause elevated triglycerides. So less common risk factors are the excessive alcohol use, the physical inactivity, being overweight, use of certain medicines, and genetic disorders. So let's take a look at some of those. So some of the causes of medications for elevated triglycerides are atypical antipsychotic medications. So that would be something like Risperdal or Risperidone, ziprasidone, quetiapine, olanzapine, Seroquel. Those are all in that class. Then also beta blockers like metoprolol or propranolol, carvedilol. And then bile binding resins, that's something called like cholestyramine that you may get from a GI doctor. Exogenous estrogen use, so anybody on hormone replacement therapy can have elevated triglycerides. Glucocorticoids, immunosuppressants, isotretinoin, that's like acne medicine. Protease inhibitors, that's usually HIV therapy. Thiazide diuretics, often used for blood pressure and for swelling, something like hydrochlorothiazide, and there's some others. And then, I'm not going to try to say this, but Ticlid, it's an antiplatelet drug that also can cause elevated triglycerides. And then there are genetic causes, which we're not going to go into, but they can cause pretty high triglycerides, often more than the 500 range. So those are often managed with medications. So why do we care about triglycerides? Let me move myself here. Okay, so the American College of Cardiology and the American Heart Association guidelines have elevated triglyceride levels as a risk enhancing factor for cardiovascular disease. So that means beyond the traditional risk factors like cigarette smoking, diabetes, high blood pressure, and elevated LDL, this this elevated triglycerides can cause an additional risk factor for cardiovascular disease. It's also a component of metabolic syndrome, which has in and of itself an increased risk of cardiovascular disease. So speaking of that, what is metabolic syndrome? So metabolic syndrome has 5 components, but you only have to meet 3 to 5 criteria to have a diagnosis. So the first one is elevated triglycerides greater than 150 or on a cholesterol medicine, a waist circumference for a male greater than 40 inches or 35 inches for a woman, a fasting blood glucose greater than 100 or on, prediabetes or diabetes medicine, an HDL cholesterol less than 40 for men and less than 50 for women. And then a systolic blood pressure greater than 130 or a diastolic greater than 85 or on any blood pressure medication. So the National Health and Nutrition Examination Survey showed that 80% of the US population has one or more criteria for metabolic syndrome. So metabolic syndrome is important because it causes insulin resistance. It increases the visceral fat. So that's the fat around your organs, and increased fatty acid production. And then, like I mentioned before, it also is associated with an increased risk of cardiovascular disease. And then patients with high triglycerides with an increased waist circumference also have a higher risk of cardiovascular disease. So what about even higher triglycerides? So very high triglycerides are a risk for pancreatitis. So triglycerides levels greater than 500 are associated with an increased severity of pancreatitis. And the risk increases linearly with triglyceride levels greater than 177. So levels between 1,000 or 2,000 or higher may be a contributing factor in 2 to 4% of acute pancreatitis cases. And so basically, pancreatitis is inflammation of the pancreas caused by digestive juices or enzymes attacking the pancreas. You can have symptoms of upper abdominal pain. It usually radiates to the back and can have some nausea and vomiting with that. And it can be acute or chronic. Treatment usually actually requires hospitalization, often in the ICU. You may need an NG tube, definitely IV fluids. And basically, it's just trying to rest the pancreas. So you usually aren't allowed to take anything by mouth. So the mechanism is understood to be from toxic effects from free fatty acids released by pancreatic lipase. That pancreatic lipase is usually secreted by the pancreas and transferred to the small bowel to help digest fat. So the treatment of elevated triglycerides. So basically we focus on lifestyle management, and the primary aim is still to reduce that LDL. Usually we want to intensify weight management. So weight loss of 5% or more can help lower triglyceride levels and improve cardiovascular risk. Sometimes I say 3 to 5% because that can even show a little reduction in the triglycerides, and increase physical activity. It's unclear which dietary macronutrient or dietary pattern or exercise regimen is the most beneficial, but I'm going to go into that in a second here anyway. So low carb, so reducing carbohydrate intake, including sugar sweetened beverages, and increasing fat or protein intake lower those fasting triglyceride levels. So a meta-analysis has demonstrated that higher triglycerides were found with increased carb and reduced fat intake. The carbohydrate sucrose contains a glucose molecule bound to a fructose molecule. So when sucrose is ingested, fructose is metabolized by the liver and promotes fatty acid production. So limiting the intake of sucrose and fructose may help lower triglycerides. However, the role of fructose in hypertriglyceridemia or high triglycerides in cardiovascular disease remains controversial. Eating foods low on the glycemic index, that just means low sugar, limits the rise of serum glucose levels, thus limiting the rise of serum triglycerides. So then we're talking about fat. So intake of any fat actually lowers serum triglycerides, and that even monounsaturated, polyunsaturated, or saturated fat. Increased intake of unsaturated fats can increase HDL cholesterol levels and lower triglyceride levels. A meta-analysis of 60 controlled trials showed that a 1% calorie decrease in carbs, so carbs replaced with the same amount of calories of fat, decreased those triglyceride levels by 1 to 2%. Eating patterns. So we're not talking about a specific diet, but eating patterns. So the Mediterranean diet may reduce triglyceride levels, potentially because it has a higher intake of that olive oil, that monounsaturated fat. It's also the only diet shown in a randomized controlled trial to reduce cardiovascular events. Another recent randomized controlled trial demonstrated that low carb diets reduce the triglyceride levels and reverse metabolic syndrome more effectively than high carb diets, independently of weight loss. So still, like I mentioned before, there's no clear consensus regarding the optimal macronutrient profile or eating patterns for patients with high triglycerides or metabolic syndrome. Overall, we recommend a low carb, higher fat, or high protein plan only, for those with triglycerides less than 500. So exercise. So exercise actually promotes skeletal muscle uptake of glucose. So triglycerides and other lipids are primarily absorbed by skeletal muscle and adipose tissue. Endurance exercise, especially of higher intensity, reduces triglycerides. And progressive resistance training also lowers triglycerides. And then obviously combining aerobic and resistance exercise are beneficial than either one alone. And actually high intensity exercise, which is more than 6 metabolic equivalents, may improve insulin sensitivity, blood pressure, and waist circumference when compared with moderate intensity training, which is 4 to 6 metabolic equivalents. So what about when the triglycerides are greater than 500? So first and foremost, we lower them to try to prevent pancreatitis. That's with a very low fat diet. So less than 50%, 15% of calories from fat, with weight, also, lifestyle, weight management and physical activity. And it's also recommended to immediately start a fibrate or omega-3 fatty acid or nicotinic acid. And then when they get below 500, then we try to focus on that LDL lowering. So the omega-3 fatty acid that we typically use is icosapent or Vascepa. That actually reduces cardiovascular mortality. It has known to prevent death. If you prevent one death out of the number needed to treat 111 over 5 years, that's pretty significant, even though the medication is expensive. So for triglycerides, 200 to 499, basically for primary prevention of cardiovascular disease, we don't usually use any medication if it's only elevated triglycerides. The goal would first be to reduce the LDL. Statin therapy can be considered in patients 40 to 75 years old if their levels are less than 500, but if they have border to immediate risk of cardiovascular disease. And then for patients with actual cardiovascular disease and elevated triglycerides, that icosapent or Vascepa that I mentioned does reduce cardiovascular mortality. So how do we determine the cardiovascular risk? So we actually have a calculator that I'm going to open here. Let's see if they save my data. No. Let me go to a different one. Here we go. So here we put in certain parameters. So basically this is an ASCVD risk estimator. So it's, predicting your risk of heart attack or stroke or any other cardiovascular disease in for 10 years time. Also has a lifetime risk. So I plugged in somebody's 50, a male, white, with a systolic blood pressure of 145, a diastolic of 85, total cholesterol of 250 with HDL of 40 and LDL of 135. And I said, no, he doesn't have diabetes. It is not on blood pressure medicine. He's not on a statin. He's not on aspirin. And he's never a smoker. So when they calculate this, it shows that he's 7.4%. He has a 7.4% risk of having a cardiovascular event in 10 years. And that is determined as a borderline risk. So the recommendations for the borderline to intermediate risk of cardiovascular disease was to consider statin therapy. Now, if I had changed some of his parameters that weren't as favorable, then perhaps it would be more than just considering statin therapy. It would probably bump him up to intermediate or high risk, and it would be recommended to start a statin at that time. So, medications to treat elevated triglycerides. So fibrates are first line therapy. And then there's also statins, niacin, and omega-3 fatty acids. So niacin even has an over-counter formulation, but it's not recommended due to the side effects of flushing. And then statins, obviously, they're used to help with lower LDL. And omega-3s, usually we focus on the DHA and EPA, and I'm going to go into those in a second. Give me a second. Okay, so omega-3 fatty acids, remember they are essential fatty acids. They're a type of body fat that the body cannot make on its own. We have to ingest them. We need them to survive. There are three main ones: ALA, EPA, and DHA. I'm not going to try to say them, but basically systematic reviews consistently do not support the use of omega-3 fatty acids for the primary prevention of cardiovascular disease. Doesn't mean they're not good for anything else. And it's not necessarily for secondary prevention, but for primary prevention. So that means someone who has not had a heart attack or a stroke, doesn't have diagnosed peripheral vascular disease or abdominal aortic aneurysm or carotid artery disease. So you can get omega-3 fatty acids from food sources, fish, other seafood, those fatty fish, salmon, mackerel, tuna, nuts and seeds, flax seeds, chia seeds, walnuts, and the plant oils as listed here, and also fortified foods, such as certain eggs, yogurts, milk, juice, stuff like soy beverages and infant formulas. And then there are obviously dietary supplements of omega-3 fatty acids: fish oils, krill oils, cod liver oils, algae oil. So like I said, they're not used for primary prevention, but they may be good for some other conditions such as arthritis, ADHD, depression, anxiety. More research is definitely needed, but they may even have an anti-inflammatory component. They are definitely recommended in pregnancy and breastfeeding. Helps the baby with cognitive growth. The FDA recommends no more than 5 grams or 5,000 milligrams per day of DHA EPA from dietary supplements. They can have some side effects, so they're not without, risk. They unpleasant taste in the mouth, bad breath, heartburn, nausea, stomach discomfort, etc. And sometimes if I am encouraging someone to take it, I might say, okay, freeze it, because it seems to not have that bad breath afterwards, or you can buy a burpless kind that doesn't have that fishy breath after as much either. And they also may cause blood thinning, and they actually have to be stopped 1 to 2 weeks before surgery. So that's all I have for you today. Here are my references. And if you have any more questions, come work with me. You can find me on Instagram at Clearwater Family Medicine, Facebook at Carrie Reller or Clearwater Family Medicine and Allergy. And just hoping to help you if you need any help. Okay, we'll see you next time. Have a good day.